The incidence of cancer has increased enough that most families today know someone who's been affected. When I ask about personal or family history, I'm trying to work out whether this cancer happened by chance or whether there's a pattern behind it. Most cancers happen by chance. They develop as mutations accumulate over time. The longer we live, the more opportunities there are for those mutations to cross a threshold and a cancer appears. That's why many cancers are common in older age. Sometimes there is an inherited cause. Inherited means a change in the DNA you're born with. It's present in every cell. It can be passed down through a family, and it carries a higher lifetime risk of certain cancers. Another situation is when cancer appears more often in a family, but careful evaluation doesn't identify a single inherited mutation explaining it. Those cases are familial. The cancer clusters, but not because of one dominant genetic fault. Families share a lot, genes with small effects, environment, habits, smoking exposure, diet, weight patterns, alcohol use, infections, reproductive factors, geography. And so shared risk factors can create clustering that looks inherited without a clear genetic cause. That kind of clustering affects how early we screen. When inherited cancer is a possibility, the type of cancer matters. Some cancers push that question higher up the list. Ovarian cancer is one of them. Ovarian cancer matters at any age, especially the most common type we see, high-grade serous ovarian cancer. That subtype is frequently linked to inherited changes in genes such as BRCA. So even when someone is diagnosed at 60, an inherited cause is still considered. Colon cancer is different. Colon cancer diagnosed before 50 has traditionally raised concern for a hereditary syndrome. That concern still holds, but over the last decade, we've seen more colon cancers in people in their 30s and 40s that don't fit classical inherited patterns. So age alone no longer defines risk. We then look at the tumor. Does it show evidence that DNA damage is not being repaired properly? That's what we mean by a repair defect. In practical terms, this involves the mismatch repair system. Markers such as MLH1, MSH2, MSH6, and PMS2 are assessed. If abnormalities are seen, that becomes the point at which inherited risk is evaluated. In many cases now, tumor features raise suspicion first. When we talk about family history, we're talking about first degree and sometimes second degree relatives. First degree means parents, siblings, children. Second degree means grandparents, aunts, uncles. What matters is the pattern. Breast cancer in a mother and ovarian cancer in a maternal aunt points in a different direction than breast cancer in a mother and lung cancer in a paternal uncle who smoked. There are also rules around how many relatives are involved. Two first-degree relatives with the same cancer or with biologically related cancers is enough to raise concern. One first-degree relative and one second-degree relative with cancers that fit a known inherited pattern also raises concern. A first-degree relative diagnosed before 50 carries more weight than one diagnosed after 70. Two relatives diagnosed young is concerning even when the absolute number is small. What we're looking for is repetition of related cancers in defined relatives on the same side of the family across generations. Sometimes the strongest signal isn't the family, it's the person sitting in front of me. Certain personal patterns are enough on their own to raise concern. Breast and ovarian cancer in the same individual. Cancer arising independently in both breasts. More than one distinct primary cancer over a lifetime, separate sites, not explained by spread. Male breast cancer in a family line that also includes prostate or pancreatic cancer. These patterns don't happen randomly. The same inherited mutation does not produce the same cancer in everyone who carries it. One person may develop breast cancer, another prostate cancer, another pancreatic cancer, another none at all. That variability explains mixed cancer types, skipped generations, and uneven severity. Sometimes the first person we identify really is the first. That person is called the proband. Earlier generations may not be informative. People died young from infections or unrelated causes. Families were small. Details were never recorded. In other cases, the family history is simply unavailable. Relatives are estranged, adopted, unknown. Some people don't know their paternal history. Some families have only one child. Some involve donor conception. And sometimes the genetic change appears for the first time in that individual. That's a de novo mutation. So, absence of family history doesn't exclude inherited risk. Sometimes the history is unknowable, not negative. Even when someone carries an inherited change, cancer is not guaranteed. Risk is not a certainty. Some inherited changes carry a large increase in lifetime cancer risk. These are high penetrance mutations. BRCA1 and BRCA2 are the clearest examples. With these mutations, lifetime breast cancer risk is typically 50 to 70%. Ovarian cancer risk is also substantially increased. For BRCA1 around 40 to 45%, for BRCA2 around 15 to 20%. These mutations are uncommon, but when present, the effect size is large. There are also moderate and low penetrance variants. Genes such as CHEK2, ATM, PALB2, BRIP1, RAD51C and RAD51D. They are more common. On average, they raise lifetime breast cancer risk to roughly 15 to 30%, depending on the gene and background family history. Higher than population risk, but much lower than BRCA associated risk. How a genetic change is passed on also matters. Most inherited cancer syndromes follow an autosomal dominant pattern. One affected parent is enough. Each child has a 1 in 2 chance of inheriting the mutation. Some conditions work differently. They require both parents to carry the change. That's autosomal recessive inheritance. These are less common, and a smaller group of conditions are linked to sex chromosomes and affect males and females differently. These patterns matter when we think about who else in the family may be at risk. There's another pattern we sometimes see in some families. Cancer appears earlier with each generation. A parent is diagnosed in their 50s, a child in their 40s, sometimes earlier. This is called anticipation. Deciding when to test is just as hard as deciding who to test. Someone in the family gets diagnosed and suddenly people start asking what this means for their life. When do I get married? When do I have children? Do I start screening now? Do I tell my partner? Do I tell my siblings? What if I find something? Testing is done when someone is old enough to understand the result and act on it. Testing children or teenagers is reserved for specific situations where early surveillance actually changes outcomes. When testing is indicated, the most informative place to start is with someone who has already had cancer. Testing an affected individual helps determine whether a specific inherited mutation is actually driving disease in that family. If a pathogenic mutation is found, that becomes the reference point for testing others. Sometimes that isn't possible. In those cases, testing starts with an unaffected relative guided by family history and tumor features. The test itself is simple: blood, saliva, or a cheek swab. It's done once because your germline DNA doesn't change. Most testing uses next generation sequencing. This reads many genes at the same time, looking for meaningful changes. In specific situations, other methods confirm or clarify findings. A focused panel targets genes linked to a specific pattern. A broader panel is used when the picture is less clear. Broader panels increase the chance of finding a variant of uncertain significance. That means a DNA change we don't yet know how to classify. It does not change management. For BRCA1 and BRCA2, breast MRI usually starts at 25, mammography is added around 30. Imaging is often alternated, so something is done about every 6 months. Screening finds cancer early, but it does not prevent cancer. Because of that, risk-reducing mastectomy is discussed. This means removal of most breast glandular tissue. Cosmetic breast reduction does not meaningfully reduce risk. Chemoprevention may be discussed, particularly in BRCA2 carriers. Ovarian cancer screening does not reliably reduce mortality. Risk-reducing removal of ovaries and fallopian tubes is recommended. This is after childbearing is complete, for BRCA1 usually between 35 and 40, and later for BRCA2. These surgeries are separate decisions. They reduce risk substantially, but not to zero. BRCA mutations also affect men. They increase the risk of prostate cancer, pancreatic cancer, and male breast cancer. In Lynch syndrome, colonoscopy starts early, often between 20 and 25, and is repeated every year or two. The goal is prevention. If cancers recur or surveillance becomes unreliable, colectomy is discussed. Lynch syndrome also increases risk of endometrial and ovarian cancer. Because screening is unreliable, risk-reducing surgery is often discussed after childbearing. The timing and approach are individualized. In Li-Fraumeni syndrome, risk spans multiple organs. Radiation is minimized. Surveillance relies heavily on MRI. In familial adenomatous polyposis, hundreds of polyps develop early. Endoscopic surveillance begins in adolescence, and colectomy is planned before cancer appears. For moderate penetrance mutations, management focuses on screening, not organ removal. Family history still matters even when genetic testing is negative. A negative test means no pathogenic mutation was identified with current methods. It does not override a strong family pattern. Family history also matters after cancer treatment. It informs surveillance, risk of second primaries, and counseling of relatives. This is how family history is used in practice as a framework for long-term decisions across an entire family. If you've liked the video, please don't forget to like, share, and subscribe to the channel for more such content.